Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Striving for Consensus on the Management of ALK-positive non-small cell lung cancer. We have a great faculty today for this think tank. Dr. Ross Camidge from the University of Colorado in Denver, Colorado. Dr. Justin Gainor from the Harvard Medical School and the Massachusetts General Hospital in Boston. Professor Solange Peters from the Lausanne University Hospital in Lausanne, Switzerland, and Professor Ben Solomon from the Peter MacCallum Cancer Center in Melbourne, Australia. Here's where we're heading today. We're going to start out just sort of chatting a little bit about ALK disease in general, and then the faculty is going to be giving presentations, which we're then going to discuss. We'll then go through some cases, actual real cases from the faculty's practice, and then finally, if we have time, we'll get into a journal club with some of the papers that the faculty has been on. But just sort of a prologue, Ben, I see this paper you had in the Cochrane Library, over 100 pages. So if anybody in the audience wants like a definitive reference paper on ALK, check this out. But Ben, it just kind of, is really a reminder of how far we've come in targeted therapy of lung cancer, how much information there is, and particularly from the perspective of our primary target audience, the general medical oncologist is also taking care of everything else in oncology. It's really an incredible challenge. Any thoughts, Ben, about sort of the evolution of the scientific literature on ALK?
Yeah, thanks, Neil. I think as you rightly point out, it really is a very rapid evolution. ALK rearrangements were only identified in 2007. But we've had the development of first generation, second generation, and now even later generation compounds. And this paper that you mentioned, this Cochrane meta-analysis, compared the randomized trials with the ALK inhibitors, and it confirmed the benefits of ALK inhibitors in improving outcomes compared to chemotherapy. And more recently, the improvements in outcomes with second generation compounds compared to crizotinib. And really what we've seen is very meaningful impacts on patients in terms of outcomes and even survival with these newer inhibitors.
So Ross, any reflections back on when this sort of all started? EGFR had just come out with the EGFR TKIs. I remember hearing the term Lazarus effect when people started talking about what was happening with these patients. Any recollections of some of the first patients you treated, Ross, and what your reaction was to what you saw?
Well, so Ben and I were part of the original team that was working on crizotinib. And I remember the first time we saw the kind of accumulated data of the responses that we were seeing in what were FISH positive cases treated with crizotinib, and had this amazing waterfall plot. And Ben and I were walking back from the conference, and I don't know if you remember this, Ben, but I said, they have no idea what they have here. And the reason was because, just as you said, EGFR was there, but it was incredibly controversial. Did it work or didn't it work if you had a mutation? But this was the second example. And strange enough, the second example, I think, was more important because it made you believe there would be a third and a fourth. So I actually think the beginning of personalized therapy, really, the wall shattered with ALK. Absolutely.
We actually just did a program the other day where we attempted to review targeted therapy of non-small cell in an hour with Zosha Petroska and Greg Riley, and we could barely even talk about not only ALK and EGFR, but as you said, a whole litany of new targets. And one of the things we got into there, and I just want to bring up briefly, we always do when we talk about targeted therapy, is some sort of generic issues that seem to come up all the time when we talk about targeted therapy, particularly in lung cancer. And Justin, of course, one of the issues has been the issue about immunotherapy, because at the same time targeted therapy was coming in, immunotherapy was coming in, and didn't quite exactly play out maybe the way we expected. I don't know what people expected, but certainly the benefits of immunotherapy in patients with a targetable mutation became a major topic. Can you talk about where we are today with that, Justin? Not only in terms of ALK, but maybe in contrast to some of the other targets, not just EGFR, but less common targets or more recent targets, NRG, BRAF, MET, and kind of across the whole spectrum, kind of what we're seeing right now with immunotherapy in patients with targetable mutations in non-small cell, Justin?
Yeah, it's a great point. I think in the early days, right, we were hoping that we could combine the high response rates of targeted therapies with the durability of checkpoint inhibitors, and really that combinations would help solve things. But of course, we now know that, targeted therapies and immunotherapies don't really mix well in lung cancer populations. Of course, there are exceptions, but it also looks like the populations who derive benefit, if we think of the Venn diagram, there are the oncogenic drivers that really don't derive benefit to immunotherapy, and it's really just all about targeted therapy. We have then wild type tumors that, where we're really using immunotherapy, and then there's the piece of the where those Venn diagrams overlap. Examples there would be things like KRAS G12C, where there's a role for both checkpoint inhibitors as well as targeted therapies. So, some oncogenic drivers that are occasionally immunogenic. So I would put, BRAF in that category as well. I think it emphasized to us the importance of the importance of testing and getting the results of testing before you start therapy, because of the challenges of mixing a TKI after someone started on a checkpoint inhibitor. And it's really underscored the importance of actually doing the clinical trials when we're combining agents, that is not just enough to take two drugs that work individually, that you actually need to examine these in the context of rigorous clinical trials.
Solange, any thoughts about why people with targetable mutations don't seem to benefit as much? You see patients who have, high PD-1 levels, high TMB levels, and they still don't benefit. And can you maybe give us some thoughts about sort of why? I mean, we hear, okay, a lot of the patients are non-smokers, maybe less mutational burden. I'm not sure I've gotten too far beyond that, but any thoughts about why they don't respond?
Yeah, thanks so much for the question. I think we have not gone so much more, I would say, in advanced thoughts than one you evoked. The most important thing is to say, and everybody listening has to keep it in mind, when you speak about oncogene addiction, you might be betrayed by the level of PD-L1 which is disclosed on your pathological report, because the expression of PD-L1 can be just oncogenically induced. So the expression, the pathognomonic oncogenic pathway leading to the malignant phenotype might also lead per se to an overexpression of PD-L1 which is not related to the actionable T-cell exhaustion that we see in smoker patients. So even if your EGFR mutant patient or your ALK positive patient has 100% PD-L1, you have to keep in mind that you cannot trust your PD-L1 to dictate any kind of treatment strategy. Then I was telling in terms of biology, we have not gone so far as compared to your sentence of summary. What we know is that some tumors are poorly immunogenic because they present a very low load of potential neoantigen. For example, here, when you do program with T-cell therapy or vaccine, we need to have more than 10 mutations which are visible by the immune system and recognized by your own HLA classes of molecules. When you have an ALK or EGFR, very often you have 1, 2, or 3 mutations only. One only is enough. It can be only one. What I mean by that is the poor antigenicity, the low level of neoantigen, is the first paradigm, and it is correlated to the never smoker habit of these patients. So that's probably why, to go back to Justin's remark, some patients with oncogene addiction might still be immunosensitive. And we have some example of metexon 14 or BRAF mutated patients who are heavy smokers and are outliers because they respond well to immunotherapy because they have more mutations. But in general, be very careful with IO in oncogene addiction. And if you have to move this way or to go down this road, try to avoid immunotherapy monotherapy, because the surprise might be very rapid progressive disease.
So Ben, this is a paper you have that I thought was really great, kind of reviewing broadly the issue of immunotherapy in oncogene-addicted non-small cell lung cancer. For us out here outside and the general medical oncologists, a lot of times we're just almost hearing, kind of how you describe your approach to it. We listen to your cases. And, when you kind of, as you did in this paper, when you try to put in perspective, for example, the different oncogene addictions, where does ALK fit in? Because I kind of have had the experience it's all the way at the end of the spectrum. I have heard people talk about cases. We had Heather Wakely in a program the other day who mentioned she had a couple of cases of EGFR that responded to IOs. But ALK, I don't know. And also, Ben, when, if at all, do you use ALK IOs in people with ALK, or do you not use it?
Yeah, that's an important question for practice, Neil. And I think the spectrum that you described, I do feel that ALK sits at the end of the spectrum where we know that single agent PD-1s are ineffective. I think that's pretty consistent. Does immunotherapy have a role? I think when we sort of run out of options, there may be a situation to combine immunotherapy with chemotherapy. For example, in the IMpower 150 regimen, where chemotherapy is combined with a PD-L1 inhibitor plus bevacizumab, that would probably be the only situation that I would use immunotherapy in this context.
So I want to get into another sort of generic issue, which is the issue of the adjuvant therapy in patients with targetable mutations. So right now, that's restricted to osimertinib and EGFR. And Ross, this is a great editorial you did about that, going into all the complexities of the ADAURA situation. But you can imagine, I know we're waiting for data. You can tell me when you think we're going to get data in terms of ALK inhibitors in the adjuvant setting. But it certainly would not be a surprise if both of these strategies end up maybe not having a survival benefit, but not necessarily being ruled out, even if they don't have a survival benefit. And you go through in your paper all the considerations in the long term that have to be considered to try to figure out what would have to be, at that point, a quality of life issue. One of the ways I can always get a pulmonary doc's blood pressure up on a webinar is to ask the audience, if you could, would you give a RET inhibitor in the adjuvant setting? And always like 60% of the audience says yes, and the faculty has a heart attack. But just kind of curious, Ross, what your thought is about ALK inhibitors in the future in the adjuvant setting. Any predictions about what you think we're going to see? Any predictions about what you think we're going to see about survival with ADAURA? But in particular, how you think this is going to play out when we really sit down, hopefully someday with all the data, and figure out what's in the patient's best interests. Any thoughts, Ross?
Yeah, I think ADAURA, the real strength of ADAURA is I think it's challenged us to think about things differently. In the old days, adjuvant therapy was designed to change the cure rate, and that was it. That was the be-all and end-all. You gave chemotherapy, you stopped the chemotherapy, and then there were some undecided voters who hadn't decided if they were cured or not, and you moved more of them to the cured. With the TKIs, I think many of us believe that obviously they can suppress disease, but in a stage 4 patient, you stop the TKI and the cancer comes back. And so the question is the same thing just going to happen with early stage disease? Hence, ADAURA's primary endpoint was disease-free survival, which is just really when you're on the drug, is the disease suppressed? And that's obviously positive. Exactly the same thing that would happen with almost every other targeted therapy. So I would imagine an ALK adjuvant will have a disease-free survival advantage. There are then two questions. One is disease-free survival a surrogate for overall survival? And if so, why might overall survival be improved? So the first one is, does it change the cure rate? And that means you're off a treatment and fewer of the cancers come back. I don't see any evidence of that so far. If you look at the updated analyses on ADAURA, sure, the disease-free survival is positive, but those curves are coming back together. The second reason you might have an overall survival advantage is the reality of doing trials on an international basis, which is it's not kind of early versus late osimertinib. It's whether you actually get the osimertinib or not. If you get it in the adjuvant setting, you get 3 years of osimertinib, and then you're on your own, in whatever country you are. And the last one is, and this I think is kind of exciting, is might have 3 years on a TKI, maybe it takes you 2 years to relapse. So by the time you're relapsing, you're seeing Dr. Peters and Dr. Solomon 5 years later, and who knows what amazing developments they will have had by then. And so we talked about the oncology time machine, that you just push patients into the future and you say, treat your disease now. And that could have an overall survival advantage too. The other one, which you want to know what puts, patients versus physicians' blood pressure up is you go to the patient and you say, well, do you want to relapse now or do you want to relapse in 5 years' time? And it's like, well, I got stuff to do now. You know, I'm going to pay my taxes later. So I think there's almost a psychological advantage to disease-free survival advantage, which I've become more sympathetic to. But yeah, to short answer to your question is, ALK's going to have a disease-free survival advantage in this setting, and we'll still continue that debate about its value.
Solange, any thoughts about where we might be heading in terms of not just adjuvant, but also post-chemo radiation? Right now we have durvalumab. We'll talk as we go through this. You know, people, and particularly now I hear a lot of people getting very uncomfortable about EGFR. I'm sure there's a lot of discomfort every time you see, I've heard ROS1 being picked up the other day. Somebody had a case like that, I mean, 2 cases like that. Any thoughts where we're heading and sort of this adjuvant or consolidation strategy in patients with targetable mutations, Solange?
Thanks so much. You're right. It's a matter of debate, right? Again, because of the pretty low magnitude of benefit of immunotherapy in these patients, it's very difficult to consider durvalumab is the way to go in oncogene addiction after radiochemotherapy. It is in many countries reimbursed. It is reimbursed regardless of the presence of any kind of driver, particularly the less frequent, because they were not excluded from the initial clinical trials. But we all know that if a benefit there is, it would be very modest, right? So that's really a question we all have, and I guess 50-50, we struggle with the final decision. Of course, what is very attractive, and I would say potentially used outside of evidence, is the strategy of ADAURA, consolidating a radiochemo in a very large volume tumor, for example, a kind of a complementary, not to call it adjuvant, a consolidation TKI. Unfortunately, today we have no data. Some trials are ongoing, some trials will help us for EGFR and ALK, but we have no data. As physicians, we have to remember that in everything we do, we sometimes take a risk if we go beyond evidence-based medicine. And if I stress that, it's probably because, as Ross was telling, the capsule, right? In ALK now we have years of survival doing what is evidence-based, what has data. So everything you do should keep in mind that you might, at some point, fragilize or put some danger on what has been established as being major projects. So I think to answer your question, first step is to have data about the role of consolidation TKI after radiochemo. So second point might be that immunotherapy in the future might be addressed or usable for some oncogene addiction patients using stronger immunotherapy. So maybe there will be alternative strategies in that setting too. But last but not least, maybe after radiochemo in ADAURA and in the ALK similar trials, there's one endpoint we'd like to look at is what is happening in the brain. And we'll discuss it later on, but maybe for ALK, the evidence might be easier to establish because in stage 3 disease after radiochemo, very often the relapse is in the brain. But again, we need data to make sure that it is rational and it's not a danger that we impose to the patients to follow our intuition there.
And of course, one of my favorite statistics from ADAURA was the rate of brain mets, which I think was 10% and without, 1% with. And Justin, it also just kind of gets more into the issue, as was mentioned before, of involving the patient with the decision. I'm curious with your more, I'm sure you've had medical oncologists as patients. So in the more educated patients, have you, for example, have you ever used an ALK inhibitor? I'm sure you have a lot of trials available, Justin, do you offer it to your patients? And also, in terms of other strategies, you hear a lot in almost every solid tumor about circulating DNA. Do you think this might in some way get factored in?
A lot of great questions there. These are questions that our tumor boards really struggle with. It seems like our tumor boards, it's increasingly complex, and these questions on, oncogenic driver, patient who has earlier stage disease, and what do you do with targeted therapy? And I think this issue is going to keep coming up. I completely agree with Solange that, we want data. The question is going to be, I think we'll be able to get it for EGFR. We're going to be able to get it for ALK. The question is, are we ever going to get it for ROS1, NTRK, RET? I think that's going to be much more challenging. When we're looking at even smaller pieces of the pie, and how much will we then extrapolate to other drivers? In my view, I think if we show that, in the metastatic setting, EGFR, ALK, ROS1, RET, behave very similarly in terms of response rates to single agent TKI, I think if you show a paradigm with EGFR and ALK, I'd start feeling better about extrapolating if there's a oncogenic subgroup where it's going to be really hard for us to actually do a phase 3 study. But I think we're going to continue to debate this. I do think we as a community in the thoracic field, I think we do need to use more ctDNA as a marker of MRD. I think the GI space, is certainly adopting that, I'd say, more quickly than we have. And I'd be lying if I said I haven't given adjuvant ALK TKI or consolidation ALK TKI. Yes, I have, but I do. I have a lot. It's more than one visit typically, and I really worry, particularly in that post-chemo radiation case, I really worry about pneumonitis, and that's what a lot of our conversation hinges on. And I agree with Ross. My feelings has evolved over time, and I do value disease-free survival, from a patient, the psychological aspects of living, not knowing that you have an incurable illness. I think there is value in that. And the last thing I'll say is I do like that analogy of the time machine, because I think all of us probably have patients, right, who, started on one of the phase 1, phase 2 studies that, even though that wasn't transformational, it got them to the next ALK inhibitor and then the next ALK inhibitor. Much like in the HIV world, the initial folks who went on AZT were then able to get on to suppress the virus long enough to get on to combination. So I think there's value there.
Ben, any thoughts on this? One of the other things we talk about is whether to use targeted therapy first line in metastatic disease. And, in ALK, it's pretty well defined, but it gets a little, hairier as you get into other mutations. And getting back to the point about, learning from one study and applying it without necessarily a randomized trial, people who are new to oncology, about 30% of our audience has been in oncology less than 5 years. They don't know about IPASS and the other trials. I think there's maybe one or two others comparing chemo to EGFR TKIs that showed that, targeted therapy worked better. We saw that in ALK, and then we just started to apply it. Any thoughts about the adjuvant or post-chemo radiation setting, Ben, and the idea that maybe as time goes on, we're not going to be able to do randomized trials. We're just going to have to make individualized decisions?
Yeah, I think it is a really important area, because potentially in the early stage setting, that's where we can have the biggest impact of these drugs. Ross mentioned all the caveats about cure, but I remain optimistic that there are a population of patients with early stage disease that will be cured from targeted therapies, and we do need to do the trials to see whether that's the case. In the case of ALK inhibitors, there's a trial called ALINA, which compares alectinib to chemotherapy, which we'll hopefully be reporting in the next year or so. So we should have some data. It has all the caveats that the ADAURA study has, and the results will need to be interpreted in that context. But we'll learn, and I suspect, as you suggested, the lessons from one oncogene will carry over to the other.
So one other sort of general point before we get into specifics in your presentations. Of course, I always review everyone's bios prior to the meeting, and I was really struck by this paper from Ross and his group, Pregnancy and Pathways to Motherhood in Oncogene-Driven Lung Cancer, something I haven't thought much about. But Ross, in it, you get into the issue of the fact that a lot of the younger patients with lung cancer, and I think in your experiences, like half of them have oncogene-addicted cancers, and the issue of pregnancy, they're going to be on therapy indefinitely, and I think the idea, I don't think we know very much about what happens with pregnancy. I wanted to bring up that there was a very important presentation at the San Antonio Breast Cancer Symposium about a month ago by Ann Partridge from Dana-Farber, who's been a leader in breast cancer in younger women, showing that it appeared to be safe So, in breast cancer, they give endocrine therapy for 5 or 10 years, and they don't, pregnancy is not advised during that time. It's teratogenetic. So they stopped it for up to 2 years, and 75% of women who wanted to get pregnant, 75% of these women were able to get pregnant. Most of them went back on therapy, and it seemed to work. I mean, of course, it wasn't completely definitive. I never would have thought about it with metastatic disease, Ross, but even if you look through the cases we're going to present today, there's a bunch of people under age 40. Can you just summarize your thought? I loved Ann Partridge talked about the idea of it's not just about surviving, but thriving, really the issue of quality of life. Any thoughts about where fertility might fit in here, Ross?
Yeah, we kind of published this paper almost as a kind of mission statement. I mean, I think it's a reflection of the maturity in the field that this topic even comes up. The idea of somebody with metastatic lung cancer even contemplating starting any kind of a family was a real hot button issue. How can you possibly be a parent if you're not going to be around? And then, as Solange already mentioned, these people are surviving years and sometimes even decades now. And because they tend to be younger people, they may be at that time in life where they would normally be starting a family. I think we're all learning through this. I mean, I've had patients who got pregnant on ALK inhibitors and they had terminations. And, and in those dark, late night moments, I wonder, was, the right thing to do? I think we are recognizing that the title of this paper is Pathways to Motherhood to cover everything. So there are options of adoption, surrogacy, but there are also case reports of patients just saying, well, I don't care what the doctors say, I'm still going to get pregnant. And at least on the basis of a baby coming out and appearing to be completely normal and functional, so far on the case report level, there are patients having conceived and carried babies on alectinib. That doesn't mean it's instantly transferable to every ALK TKI. They hit other pathways. We don't know where all of these things are involved in kind of organogenesis. But I think this paper was about saying, look, let's bring this out into the sunlight. Let's start to talk about it. Some of it is biology. Can we do better studies on fertility in terms of whether these drugs are actually safe to use? Some of them are societal. There are some adoption agencies that say you've got a diagnosis of cancer, you can't adopt. Is that the right thing? And you go, well, maybe 10 years with a really good parent that cares is better than a lifetime with a terrible parent. So I think this is what we need to start to talk about as a field.
Solange, any thoughts? I think this latter thought that Ross brought out is something I haven't heard. I didn't hear in the big discussions we had about breast cancer. And I should clarify, that was in the adjuvant setting, which is very different than metastatic setting. But I think the points that Ross brings up in terms of, if that you have a chance to live 5 or 10 years, is it, something that should be offered as a possibility to a patient? Even in terms of adoption, surrogacy, et cetera. Any thoughts, Solange?
I think Ross made an amazing and passionate call with this article, because the first question is, what does it mean to be in good health? And for a young woman, being in good health, when you have a long survival, years in front of you, is sometimes meaning also having sense in this life. And sense might be a mandatory wish of having a family, a group of people around, also building the family, creating your relationships, might be per se part of a well-being, participating to a good health. But this is a kind of I wouldn't say a luxury thought, but this is a new thought, because in the past, at the time we started, Ross, Ben, Justin and myself, it was 8 months survival lung cancer, 8 months. Now we speak about years. So that's all of a new thought about considering how the regulation and the law could follow really a societal move, which is about being survivor of metastatic lung cancer. I think we have to take into the balance the health of the mother and the society requirements to be a parent. In Switzerland, it's extremely stringent. You need to be, for more than 10 years, you have to give the security that the patient will be alive and in good health to be able to adopt a kid, which is difficult for a doctor, whatever the circumstances, right? But it's extremely stringent. But I think the society has to rethink what is a model of family. Can it be only one parent? And what is the sense of having a kid in our families today? And it's a very good call, thanks to the advances. I love the breast cancer study too presented at San Antonio, because it just tells us that sometimes you can balance a certain degree of risk for the parent, for the mother, to release this willingness of creating something which will persist whatever happens to you. And I think both contribute to a choice which is necessary for health.
And, Ross, it's interesting because actually this idea of being a parent, but maybe only going to be around for 10 years, you think about it, Mick Jagger, I think, had a child over the age of 70. So when you think about men in particular in their 70s or older, really it's just, and let me tell you, I've thought about it myself, the idea, that you have the same exact issue, right?
Yeah,
Anyhow,
we don't say you're too old to be a parent. Yeah.
Right, exactly, and it's kind of, sort of similar. All right, well, let's get into the nitty-gritty and particularly your presentations. And so we're going to start out. Ross is going to talk about optimal identification of ALK-positive disease and some of the issues related to testing. Just to let the audience know, we gave the faculty, since we know most of you end up listening to these webinars. We do all these slides and video, and people end up listening in their cars. So because of that, we gave the faculty the option of using slides or not. And 3 of the faculty said, yeah, but Ross said, well, I think I'm just going to take a shot at, kind of talking. We're going to get into the issue of choice of ALK inhibitor. And of course, that's going to be one of the more interesting things. I just want to point out a really great pro and con debate and controversies in thoracic oncology. From the Journal of Thoracic Oncology, Ross took the anti-lorlatinib, and a couple other people did the pro-lorlatinib. If you want to see a lot of the discussions that we're going to flesh out, check out those 2 papers. But Ross, here's a list of things we gave you to talk about, and we've chatted about these things verbally many times, and we're going to ask you to just kind of tell us your thoughts about these issues in terms of identification of ALK.
Great. So yes, in the interest of safe driving, this will all be auditory and there'll be no visual demonstrations. So when we're talking about identifying ALK-positive lung cancer, let's break it down into 3 categories. So first of all, are you actually doing any testing at all? And the only reason why you might do no testing, and we know that's an issue, when people do studies, some people just don't get tested. I would argue would be if you've already found a driver oncogene. These things tend to be mutually exclusive, and probably that's acceptable in that situation not to have tested for ALK, although officially you're supposed to be testing. The other situation would be you can't get tissue. There's the patient who, for whatever reason, the disease is inaccessible or it's high risk. And there you've got 2 options. One is obviously you can send off circulating free DNA. The other one is to weigh up the pros and cons of the patient likely to have a driver oncogene and, versus the risks of the biopsy. So somebody who has terrible emphysema and is a 100-pack-year smoker, the risk of getting, and they only have disease in their lung, the risk of getting a biopsy may not be worth it because their chance of actually having a driver oncogene. But yes, in the modern world, we should be testing everybody for everything, and we should be testing it in parallel, but it's not an ideal way. It may be a modern world, but it's not an ideal world. The other thing I tend to see is when people do the testing, we have to talk about false positives and false negatives. So there are still people who are doing immunohistochemistry for ALK, FISH for ALK, which was the first companion diagnostic, and then there are PCR-based methods and then next-generation sequencing methods. I think, this is applicable across the whole world. It is better to do some testing than no testing. But you have to understand that with the exception of next-generation sequencing, false positives do occur. So if we take, for example, the ALEX study, where the entry criteria was immunohistochemistry positive for ALK, they were able, amongst those IHC positive cases, to then do secondary FISH analysis. And if you were IHC positive and FISH negative, which was about 15% of the patients, your response rate wasn't 80%, it was about 20%. So clearly you can get false positive with immunohistochemistry. The same thing can happen with FISH. It is a nuanced assay. You can have degradation of the tissue, you can have stretching of the DNA and when it's prepared, and you can get false positives. I think the key thing there is if you have an assay which is not next generation sequencing, and you put the patient on an ALK inhibitor and they do not respond, the solution is usually not another ALK inhibitor, the solution is to doubt the diagnostic accuracy of the test. I was asked to consult on a patient the other day, and the daughter phoned me up and said, my dad is ALK positive and he's on an ALK inhibitor. He just blew through alectinib. Where should we go to next? And then you dig down to the details, and dad had a 67-pack year smoking history. He had COPD, and he was diagnosed through IHC positivity, and he had absolutely no response on the first scan. And then they did some additional testing. They had KRAS mutation, so it was a false positive. I think the other thing I'd like to talk about in terms of false negatives are certainly cfDNA. So I think that has become an easy kind of route to damnation for some community oncologists, because you send off the cfDNA, you don't find anything, and you say, I've done testing, there's nothing there. A negative result on cfDNA isn't really worth very much. If you find a positive, it means something, but if you don't find something, it doesn't mean there's something there. And particularly in a patient with a low smoking history or a young patient, I would really be pushing for a tissue biopsy. The other false negatives you get are, again, the starting material that you might have. So pleural fluid, where you've got a lot of contaminating mesothelial cells, you can get a false negative there. Bone biopsies, where the decalcification, particularly if you're using a FISH assay, you can get sort of degradation of the signal. So I think the headlines are, we're all moving to next generation sequencing. It's got a very low false positive rate. It very much does everything on everybody at the same time. IHC and FISH you may have to use because that's in your system and that's fine. But if the patient isn't behaving as the results said, doubt the diagnostic, not the efficacy of your initial drug.
I just want to follow up and ask, you were saying, and you were mentioning this case of the patient who, quote, blew through alectinib. The other day on that targeted webinar I was mentioning, one of the people in the chat room asked about a case of a patient who progressed after a year and a half on lorlatinib. And I was like, that really sounds a little bit off. What's sort of the lower end of what you see, Ross, and when do you get suspicious? Would somebody who progresses after a year and a half make you nervous that maybe something else is going on?
So we need to draw a distinction between clear evidence of benefit and then the development of resistance. And there we know, and I'm sure this will come out in the later discussion, that the different mechanisms of on-target and off-target resistance probably do have different timings. So off-target resistance, the development of a second driver, tends to happen a little earlier. On-target resistance tends to happen a little later. So that would be okay. But if there's no benefit at all on that first scan, that's when I get really suspicious. A year and a half, I'm assuming there were some scans that showed benefit, unless it was like stable disease, in which case maybe they just have really indolent disease.
So, Justin, I'm curious how you approach patients who are non-smokers and yet on next generation sequencing don't have anything. You just go on and treat them as a patient without a mutation. What about RNA sequencing, other assays? And when you do that, what do you find?
You already led me with it, which is, when we say NGS, there can be DNA-based platforms or RNA-based platforms. RNA in particular can be helpful for fusion detection, just because commonly the breakpoints of rearrangements are within the introns. And so if you use a DNA-based platform, commonly have to tile along the introns. Whereas by using an RNA-based sequencing platform, it's much easier to find the rearrangements, finding whether they're functional. It can also be more helpful for some other alterations like MET exon 14 skipping. There are so many different point mutations and alterations that can lead to MET exon 14 skipping that you may miss with a DNA-based platform. Whereas if you use an RNA-based platform, you're just looking for the absence of the transcript corresponding to exon 14. So, in a patient where I have a high pretest probability that they may have a driver, I go through the algorithm that Ross mentioned, which is, what was the quality of the specimen? Was it a bone biopsy? What was the sequencing diversity? So talking to my molecular pathologist, and I would be prioritizing RNA-based sequencing in that patient.
So, Ben, with EGFR, we hear about all kinds of EGFR mutations, and some respond, some don't respond to TKIs. What about in ALK, sort of molecularly? Are there different fusion partners, and does that change how people respond?
Yeah, so there are. The EML4 is the most frequently observed fusion partner, but there are other fusion partners which are less common. And even within EML4 ALK fusions, there are what we call different variants, where the breakpoint is located differently. And there do seem to be some differences associated with the variants in terms of outcomes, particularly with the with crizotinib, maybe less so with the later generation ALK inhibitors. There are some differences between variant 1 and variant 3, for example. But I'm not sure that these variants at this point, I don't think they really influence clinical practice in terms of which drug you use in which context. I don't think we have enough information to guide us in that respect.
Solange, what about ALK outside of lung cancer? I think every now and then I've seen cases, and I think I've even seen reports of response to ALK, and I think it might have been lymphoma. You know, we have BRAF now with a pan-tumor indication. What do we know about ALK outside of lung cancer, and do you know anything about whether or not ALK inhibitors work outside of lung cancer?
Well, there are several cancers which might harbor ALK alterations, several cancer types, which can be rearrangement like in lung cancer, myofibroblastic tumors, sometimes from lymphoma, as you said, but might also be point mutations, as you can find sometimes in neurological diseases. So, of course, the alterations are not the same, but in many of these disease entities, which might sometimes be extremely rare, it has been shown through cases and case reports that ALK inhibitors might play a role. It's quite important to stress this in myofibroblastic tumor, for example, and some of these lymphoblastic T cells tumor where the ALK inhibitors look like working. Of course, most of the data I've seen, maybe my colleagues have seen others, have been using at the time being the classical old days for us, crizotinib. But still, it looks like that these data provide a mechanistic need to try at some point, maybe not in first line, but in later lines, an ALK inhibitors if you find one of these alteration, and if you have rational reasons to think it is a driver of the tumor. It is also rarely found. I had some cases of cholangiocarcinoma, of biliary tract diseases which were rearranged for ALK, and we find also some kind of rare thyroid cancers which might harbor ALK alterations. So it's quite important to keep it in mind, but again, in the lack of strong evidence-based data, when you try to start targeted therapies in these diseases, it should not be a frontline strategy like ALK in lung cancer. It's probably a later line of treatment after you have exhausted what has been established as standards.
So we may get into this later, particularly with the cases, but Ross, what about further mutation testing on disease progression? Oncologists hear a lot about doing that in EGFR, although they have a lot of questions about what to do with it. In EGFR, you have the issue of transformation to small cell. Incidentally, I don't know, does that occur with ALK? And also, what about repeat mutation testing, liquid biopsies, Ross? From a practical perspective, outside of research, is there any reason for a doc in community-based practice to do that?
So thanks for that question, Neil. So it's a kind of similar argument. So one of the things to realize is that when people on a targeted therapy develop acquired resistance, they don't always just turn back on the same signaling pathway. So it's in the same way that we believe there's a pie chart of different driver oncogenes at the start, there's a pie chart of different mechanism resistance at the time of acquired resistance. Of course, the drug companies are very keen to say, well, you just need another ALK inhibitor. And Ben already mentioned, I think we're up to 4th generation ALK inhibitors. And so that's the answer for some people who have on-target resistance. And some of this might come out in some of the cases we discuss later. But the elephant in the room is about the 40 to 50% of people who do not have an identified ALK resistance mutation. And we believe they have some kind of a second driver. Now, that might be simple. Another pathway is turned on, and we can identify it through amplification, gene rearrangements, mutations, all the stuff that we might look for initially. But there is histological transformation. Small cell transition has been described. I think there's a nice paper from Justin's site that sort of showed it was 2%, 5%, something like that. You can look on cfDNA. Again, if you don't find it, it doesn't mean it's not there. And, why do the testing? For me, the reason to do the testing is if your patient is sitting there and they have in their head the idea that what they need to do is go onto a clinical trial for a 4th-generation ALK inhibitor and travel halfway across the country, if they have a second driver, that's a complete waste of their time. So I do actually think that getting some kind of idea of what the mechanism resistance is can still help the patient, even if it's not just, oh, well, that's only available in a clinical trial. You can also determine when a clinical trial is inappropriate.
That's a great point. Justin, actually, I never even thought about the idea of small cell transformation and ALK. Anything you want to say about that? We were talking about that the other night in terms of EGFR, and we were bringing up the issue, or can you get hints from that, from the liquid biopsy? Anything that sort of could clue you in that you really need to look for tissue?
Yeah, so what we've seen is, it's certainly less common than what's been seen with EGFR mutant lung cancer, but it happens. Indications, if you see P53, but obviously P53 is the most common co-mutation seen in about 40% of patients with ALK fusions. And so, that to me isn't really going to be the marker. It's really a tissue-based one. It's uncommon. I think using your clinical judgment, is there one lesion that's starting to explode? Those are some of the factors that underscore maybe this has transformed. At a higher frequency, we see EMT. If you do IHC for EMT markers, which I think tells you how resistance is emerging, but that's really not gonna alter your decision making clinically. I completely agree with Ross about the value of a repeat biopsy to tell you, is this tumor still ALK dependent to just with a more potent or structurally different ALK inhibitor, or is it something that a combination or even chemotherapy may be more appropriate for?
I feel like I hear P53 mentioned almost every time we do a webinar on anything. Any specific significance, Justin, in non-small cell lung cancer, specifically ALK?
Well, specifically to ALK, there have been retrospective series suggesting that, outcomes are worse if you have a concomitant P53 mutation. It could be speaking to some underlying genomic instability, predisposing for more resistance. But, right now, it doesn't alter my decision making when it comes to therapy. So, on the population level associated with a faster time to progression, but on an individual level, doesn't change decision making.
Ben, any resistance mutations that are treatable? The one I hear about, or we hear about with EGFR is MET. I'm not sure exactly how treatable it is. Anything that you see not infrequently on progression with ALK inhibitors?
Yeah, exactly as you mentioned, MET amplification can be seen as a mechanism of resistance, and as Ross was describing, a non-ALK driven mechanism of resistance. And it seems to be more common with the newer generation inhibitors, including lorlatinib, as was very nicely shown by a series from Mass General. And I guess the key thing about identifying that is that given that we have MET inhibitors available, it is possible to combine an ALK inhibitor with a MET inhibitor, and potentially that can lead to benefit.
Hey, you got a bispecific, Not that it necessarily would work, but right. I'm just happy you have one.
Yep, additional options. Yep, for sure.
You actually beat myeloma and lymphoma to getting a bispecific in practice. So congratulations on that one. Ross?
So it's funny, I got to give a call out here. So there is actually a planned study of adding in amivantamab to ALK inhibitors. I think Justin's going to be part of that study. Tejas Patil is leading that one. So as usual, you're way ahead of the game, Neil.
I just listened to what's going on. Interesting. So why don't we move forward and we'll take the gloves off and get into the interesting, fascinating, controversial discussion about choice of ALK inhibitors. I just think it's amazing that for a disease that's pretty uncommon, how many options have been developed. I mean, it's just great to be able to do this, even have this discussion. So, Justin, could you please review this?
Yeah, so thanks so much. So I'm going to be talking about our first line data, and so a lot to review, as you already alluded to. We've already alluded to this as well, with our nomenclature, but I think it's helpful to take a step back. We've really been fortunate in the field to now have, 3 generations of ALK inhibitors with approved agents, and as Ben alluded to, a 4th generation currently in clinical trials. So under first generation, we have our good old crizotinib. Second generation, we have multiple agents. Among agents approved in the US, we have ceritinib, alectinib, and brigatinib. Ensartinib approved in China. And then a 3rd generation inhibitor, lorlatinib. So how do I think about these agents? For those of you who are viewing the video, I've put their structures just to show that these are distinct agents. So they do have different profiles. So if you compare, preclinically the 2nd generation drugs, they do have slightly different selectivity profiles when it comes to various mutations. But if you had to kind of broadly lump them together, and we think about the importance in drug development of developing next generation drugs, how these agents differ is you generally see increasing potency when you move from 1st to 2nd to 3rd against the target, so against ALK. You see increased CNS penetration, or then you see increased coverage of ALK point resistance mutations. So that's how I generally think about these agents. What I've done here is really summarizing the different comparisons of 2nd generation inhibitors versus crizotinib. So a common control arm, so to speak, and recognizing that while we shouldn't perform cross-trial comparisons, at the end of the day we have to choose one drug for our patient, right? So how do we think about this? I'm not going to talk much about the ceritinib ASCEND-4 data, just because it was ceritinib versus chemo, and we know that while ceritinib is an active agent, has a lot of GI toxicity, and as we've gotten better agents in the clinic, use of ceritinib has certainly faded away. So if we think about studies of alectinib, there are actually 3 randomized studies of alectinib versus crizotinib. We have the global ALEC study, which Dr. Peters was lead author on, published in the New England Journal. And here we saw significant improvement in progression-free survival with a hazard ratio of 0.43. I should add that anytime you're talking about these studies, depending on whether you're focusing on investigator assessment versus blinded independent review, the numbers may vary a little bit. Some of these studies, for example, the ALEC study, after the primary analysis, they stopped blinded independent review, so we're just left with investigator assessment. So I've tried to designate this in the slide when I'm talking about certain numbers, whether it's investigator or blinded independent review. But essentially, if we look at now 3 studies of alectinib versus crizotinib, ALEX was a global study, J-ALEX was conducted in Japan, Alicia conducted in China. We see remarkably similar results, with alectinib consistently beating crizotinib with hazard ratios anywhere from 0.22 to 0.43, very high response rates. Moving on to ALTA-1L, Dr. Camidge was lead author on this study. So again, we see with brigatinib versus crizotinib, brigatinib producing a significant improvement in progression-free survival with a hazard ratio of 0.43, kind of identical to ALEX when viewed from an investigator standpoint. And we're talking about progression-free survivals that are now exceeding 30 months in the first-line setting. For completeness, I'll talk about EXALT-3, which is on the far right, ensartinib versus crizotinib. Hazard ratio is 0.5. Again, consistent benefit with the 2nd generation inhibitor versus crizotinib. And we now have updated data, and I showed both of these. On the left is the ALEX update, and on the right is the ALTA-1L update. And I think it's going to be helpful as we start talking about the big elephant in the room is what I think most community oncologists want to know now is, what do you start first line? Do you start with a second generation drug, brigatinib, alectinib, or do you start with a third generation inhibitor, lorlatinib? And so, there's going to be some of the curvology, comparing across these trials. I think it is important, if we look at 3-year landmarks in these studies where for progression-free survival, we're in that 40 to 45% range, progression-free at the 3-year landmark. One important note on survival, I think we've all talked about, we were alluding to this when we were discussing ADAURA, that the importance of seeing a survival benefit or not. I think importantly, the study design can influence this. And I think that the best example of that is by looking at the JALEX study versus the global ALEX study, right? These are both studies looking at crizotinib versus alectinib. We could talk about slight differences in dose, population, and testing modality to get on the studies. But, JALEX, no survival benefit, right? Curves are basically overlapping. This study allowed crossover. Global ALEX study on the right, there is a survival benefit, crossover not allowed. So I think this tells us that how we design our studies can influence this. And so I don't necessarily need to have a survival benefit as a gold standard, at least here. ALTA-1L, no difference in survival, but again, a crossover. One important metric for ALK positive when we're dealing with ALK inhibitors is what is the CNS penetrance of a given agent. We know that ALK positive tumors seem to have a tropism for the brain. And so it's really important, especially as patients are living longer, that we have agents and can control the brain because that's a major source of morbidity and mortality. So we see it pretty much across the board with the second generation agents, high response rates. And we see compared to crizotinib, really the cumulative incidence of brain metastases with alectinib is markedly lower compared to crizotinib. And looking at the data in a different way with ALTA-1L, here we're looking at intracranial progression, again, less intracranial progression with the second generation agent brigatinib. Now, so that takes us now to the CROWN data. So I've shown you a lot of data comparing second generation inhibitors versus crizotinib. We know that when patients progress on crizotinib or progress on a second generation inhibitor, that the third generation agent lorlatinib has shown high response rates, particularly if you're still ALK dependent with an ALK resistance mutation. So here, this study led by Dr. Solomon, published in the New England Journal, and then more recently in Lancet Respiratory Medicine was the update. This is now with 3 years follow-up comparing lorlatinib versus crizotinib. We can see a significant improvement in progression-free survival with a hazard ratio of 0.27. But what's really striking in my mind is that with 3 years of follow-up on blinded independent review, we still haven't hit the median. And so if we look at the 3-year PFS rate, it's 63% and really only came down about 5% comparing year 2 versus year 3. So I think this is striking. And then when you start breaking down intracranial progression, here, this is freedom from intracranial progression. On the left is patients with baseline brain metastases. You see a hazard ratio of 0.1. And on the right, this is patients who enrolled without baseline brain metastases. It's really striking, a hazard ratio that looks more like a p-value, 0.02. Really only one patient seemingly progressing in the brain who came on to the study without brain metastases. So I think this underscores the CNS penetrance of lorlatinib. I think one of the issues as we're going to be talking about in our discussion, though, is I think the two principal arguments when people look at this data and say, I'm going to stick with a second generation inhibitor instead, and is one, a sequencing argument, that is want to kind of save another line of targeted therapy. And then the other argument is one of toxicity, that lorlatinib does have a unique toxicity profile compared to some of the second generation inhibitors. Here we see that higher rates of hypercholesterolemia, but I think the bigger thing that many of us have seen with this agent are these neurocognitive or mood disorders, which are seen, as we can see on the left, in a significant proportion of patients. My experience is that typically with dose reduction, dose holds, those improve. And so I imagine in our discussion, we're going to be talking a bit more about, as well as our cases, experiences managing the neurocognitive toxicity. So how do I make decisions? So what are some of the factors I take into account? Certainly, medical comorbidities. So does someone have some baseline neurocognitive issues? Does someone have baseline mood disorders, baseline brain metastases, burden of disease? We absolutely also need to factor in patient preference, and having an honest conversation about these issues. And then we heard a little bit about molecular features. I personally don't incorporate that into my decision making yet. So in summary, management of ALK fusion positive lung cancer has evolved dramatically over the last several years. We now have 3 generations of ALK inhibitors that have approvals. I've talked about how potency, CNS penetrance, and coverage of ALK resistance mutations increase with each successive generation. And we now have 4 agents that have beat crizotinib in head-to-head studies. 3 of these, alectinib, brigatinib, and lorlatinib, are approved in the first-line setting. Personally, I don't think we should take a one-size-fits-all approach. I showed you the factors I consider, but if pressed to use one versus the other, based on the updated Lancet Respiratory Medicine data, I have been using more first-line lorlatinib based upon that data.
It's interesting. Actually, until recently, you were one of the few people who kind of said they had an inclination toward lorlatinib, and now I'm starting to hear more people talk about it. Very interested to get the thoughts of the faculty. Before I kind of go through the faculty and get each one of your take on this, I'm just kind of curious, in general, what do you see with investigator assessment as opposed to blinded assessment? Justin, more responses and better outcomes with investigators?
We always love our own children more. In general, there's a slight, trend, but the numbers only differ a little bit. I don't know what do others feel.
I totally agree with Justin. I think the point estimates then shift, and if people start to go, well, this is point something better than that, that could just be the noise of investigator. The hazard ratios tend to stay fairly similar.
Yeah, we tend when we have an experimental arm to try to believe in our own children, right? And maybe to prolong a little bit the treatment. So we might delay the conclusion of a progressive disease a little bit. But again, I'm not sure it really was observed and strongly demonstrated across various data sets. So it's more a feeling, but of course, PFS might be slightly different using that.
Lorlatinib, I think, was designed specifically to get into the CNS. It kind of reminds me, I don't know if you've heard of the drug tucatinib in HER2-positive breast cancer, now colorectal cancer, also in breast cancer designed to get into the brain. Like, how do you do that? Is it just sort of empiric, or how do you design a drug to get into the brain?
Well, I mean, some of the things that you look at are, is this a PGP substrate? Things that may get pumped out more. If you look at the structure of lorlatinib, it's this macrocyclic. It looks very, very different compared to the others. Part of that was to try to cover all the resistance mutations. But some of the features are in your, as you're nominating drug candidates, right? Looking at in your murine studies, CNS penetrance, and trying to optimize, those with the most penetrance.
Just along the lines of what Justin was referring to about the structure of lorlatinib, it's a macrocyclic or a circular molecule, which means it's more compact. And what that allows it to do is to get into the ALK binding pocket, even in the context of certain mutations that keep other drugs out. But it also facilitates the entry into the CNS.
That's interesting. I think I read something about CSF levels. Am I right? Has that been looked at, Ben?
Yes. So in the phase 1/2 study, there were some patients who had CSF levels done, and you do get pretty good CSF concentrations, and that translates clinically to responses in leptomeningeal disease, and some of those responses can really be quite durable, even in patients who've progressed on second-generation ALK inhibitors.
So let's stick with you, Ben. First of all, do you think, based on your clinical experience, it's hard to imagine anybody could see enough patients to have an opinion on this, but you all actually do. Based on your clinical experience, do you think there's a difference in CNS activity of these drugs, clinically that you can see?
I think there is. I think the first thing to say is that the second generation ALK inhibitors are very active in CNS metastases, and patient who presents with newly diagnosed brain mets, that really does create a case for starting with the TKI and deferring radiotherapy. And there rarely is a role for whole brain radiotherapy in particular in this context. But comparing the different ALK inhibitors, we do see increased CNS efficacy with lorlatinib compared to the other inhibitors, and that's I guess Ross has previously commented on this. One of the striking features in terms of response rate of lorlatinib in patients progressing on second generation inhibitors is in fact the CNS response rate compared to the systemic response rate.
So I'm going to ask you in a second, Ben, for your view in terms of first-line therapy, but you brought up the brain met thing. Of course, we talk about all the time. And, other cancers, breast in particular, uses lung as an example of that, because now they're doing that in some situations. And we know there's great activity, but how much symptoms would it take, Ben, to get you to use radiation therapy? I mean, it's one thing if the patient's completely asymptomatic, but I mean, if they have cerebral edema, or is there anything that's going to get you to use radiation therapy or even surgery?
Yeah, I think there are some situations where surgery is important in terms of patients who have very large lesions with significant mass effect and need something done very quickly. But I think in most situations, with response rates north of 80% with some of these newer drugs, we can rely on these drugs to get CNS control and defer radiotherapy. Now, there are nuances to that. With stereotactic radiotherapy, we can treat brain metastases with less morbidity. But I think for most patients, whole brain radiotherapy is something that really can be put aside.
So let's see if we can kind of do sort of a mini debate here. First of all, I just kind of want to clarify what your position is, Justin, to start out with. Do you think that beyond alectinib and lorlatinib, any of the other agents should be considered? It sounds like you feel like it's reasonable to bring both of these up as possibilities to patients and discuss them as options and maybe involve them in the decision. Is it pretty much those two drugs, crizotinib, brigatinib, any situations where, again, first line, you would do that?
I think crizotinib is the wrong answer. Unless you're talking about a ROS1 patient, there's a little bit more debate there. But, and I would say that ceritinib right now, based on its toxicity profile, would not enter into the conversation. In my mind, it's among the three. It's brigatinib, alectinib, or lorlatinib. I think that is the conversation. And more broadly, though, it's more, are you a person who wants to start with a second generation inhibitor, in which case it's alectinib or brigatinib, we can talk about differences there, or start with lorlatinib? I think that is the critical question. I tend to be a person, who favors starting with a third generation inhibitor.
Just to clarify, though, what would be a scenario where you would start brigatinib first line?
So a situation there would be if I had a patient, and this has certainly been the case, Ibi Dagogo Jack in our group recently published a paper trying to look at factors associated with the neurocognitive and mood effects of lorlatinib. And some of the things, made sense, baseline neurocognitive issues, baseline mood disorders, history of SSRI use. So if I had a patient who already had pre-existing mood disorder, or I was concerned about the neurocognitive effects, that would be a person where I would worry about upfront lorlatinib, and I'd use a second-generation agent. And there, I think alectinib or brigatinib both would be perfectly acceptable agents.
Okay, so Ben, I think we've heard his thoughts about currently, today, how he's approaching this. Agree, disagree, or in between?
No, I agree with Justin. I think there are currently 3 very good options. I'm not sure there's a wrong answer, and I think I do like Justin's description of not following a one-size-fits-all approach. I think the sort of the efficacy arguments are compelling in favor of lorlatinib. I think the toxicity is a consideration, and I think that paper from Dr. Dagogo Jack is really quite helpful in identifying patients who you may want to use a different agent to lorlatinib or consider starting with a reduced dose. But I also think, and we'll talk about this later, that the toxicity is manageable with dose reduction. And I think that I think docs need to use drugs that they're familiar with managing, and I think the learning curve is probably a little bit steeper with lorlatinib than some of the other drugs, but I think people have been using lorlatinib in the later line setting and making their way up that curve.
So before I go to Solange, just to clarify again, because I kind of felt like before lorlatinib came along, I was hearing from you all a preference of alectinib over brigatinib, but now it kind of sounds like you're open to both. So Solange, how do you think about the prior to descriptions of the way they approach it? Is that the way you do it?
Well, I agree with the colleagues. I think it's a gray zone where even teams sometimes are divided to know what is the best choice in general, as trying to write guidelines for the institution, for example. First of all, because one size does not fit all, and I would say probably crizotinib is the wrong answer, but maybe one of the correct answer might be lorlatinib in patients with brain mets. Because once you have brain mets in ALK-positive disease, the risk is that it's not only the one you can count, but additional ones. And here we know that lorlatinib has the best control. We also know how detrimental can be symptoms related to brain mets in patients. So in my institution, at least, we have made this decision that maybe with the exception of a unique brain met, which is very rare in ALK, brain metastatic patients receive frontline lorlatinib. Otherwise, it remains a discussion to have. I would rather favor, like Justin and probably Ben, who is very moderate today, to be very, I'm sure, wants to be very transparent in the way, being the main investigator of CROWN. But I would say I would probably favor lorlatinib for 2 or 3 reasons. First, the evolution of the curve over time. I've been presenting that the median PFS of alectinib was 36 months. And when you look at the current curve of lorlatinib, you are at 3 years of follow-up, and they are way above 60% of the patients who have not progressed, and the curve is flat, meaning that the PFS on the lorlatinib might be significantly longer, really significantly longer than alectinib. And PFS is very important for this patient working, having a life, and having also probably the motivation to maybe have some follow-up for toxicity. Second, Ben has been showing that even if you reduce the dose of lorlatinib, the effectiveness, the activity looks to be conserved. So if you have to do that, and very often you have to do that, that's a moderation of a dose which is acceptable for the preservation of the activity and the quality of response, probably the duration of response. So I would say, if you are prepared with your patients that some toxicity might happen and you might have to adapt the treatment accordingly, I would say I like the oldest strategies, telling that you might have to start with the best treatment first. And honestly, with the numbers we have now, the best treatment is lorlatinib. Maybe last thing about alectinib versus brigatinib, if you have to give up lorlatinib, or if you want to go with a second generation, that the fact of habitude, unfortunately in Europe, we had a very late access to brigatinib as compared to the US, meaning that most of the investigators in Europe will use alectinib first. Of course, brigatinib in case of toxicity to alectinib, like muscle pain, but in general, alectinib has been faster established also in Eastern Asia than brigatinib. And as being oncologists, unfortunately, sometimes habitudes define a market. So it's important to stress it for our environment.
So Ross, I found the paper you wrote, as always, was very colorful. I really enjoyed it. I know you were given that topic. I don't know if that actually completely reflects the way you approach clinical decision-making outside a trial. What do you think about the viewpoint just expressed by your three colleagues? Agree, disagree, or in between?
Oh, I'm sure I can find something to say. So the first thing is that article was written as a pro and con, and I was actually the reviews editor, and the instructions given to the authors and to other authors in that series is give one side of the argument, which is what we normally don't do. Normally we try and moderate, but we were trying to sort of really, fire people up. So I gave a strong argument against lorlatinib as the first-line therapy. But let's unpack some of the stuff that we know and we don't know. So lorlatinib is a pretty amazing drug. It has very good CNS penetration, and it has this amazing results from CROWN. I'm going to disagree a tiny bit with Solange here. I actually think the most dramatic CNS efficacy of lorlatinib is in protecting the CNS. That flat line is for people who don't have baseline brain metastases, whereas if you look at the people who do have baseline brain metastases, it still comes down. So I think a lot of the strength of lorlatinib is in CNS protection. And I'd also raise the idea that this may not just be because it's an ALK inhibitor that gets into the brain. It has other activity, including against NTRK. And there's some data from breast cancer where wild-type NTRK may be involved in seeding brain metastases. The reason that matters is people are developing fourth-generation drugs which supposedly have the same CNS penetration as lorlatinib, but without that NTRK activity. So will we see the same protective effect or not? That will emerge over time. I think my biggest issue and what kind of really drove the con argument is, we've all had patients who've started on alectinib or brigatinib, I'll get down to that in just a second, who do amazingly. They can be 5, 6, 7 years out and they haven't progressed. And again, if you look at the PFS curves in something like ALEX, it's a biphasic curve. There are people who progress before the median, and then there's quite a long plateau afterwards. So maybe there are people who don't need to start on lorlatinib first, and you could use it second line. I mean, these patients are not dropping down dead between first and second line like we used to have. And so, maybe the cumulative effect of second generation followed by third generation might have the same absolute benefit and also reduce your time on the more toxic or more expensive drug. So that's kind of why I'm still starting people on a second generation drug. And then keeping a pretty close eye on them. I think one of the things that we've kind of touched on, but it would really good to get the other panel's member, is what dose of lorlatinib do they actually start their patients on? So Ben's study, 100 milligrams is what you're supposed to start them on, but Ben, is that what you start them on?
Yeah, so an important question, and I think in terms of selecting the dose, the recommended phase 2 dose from the phase 1 study, there was some debate over 75 versus 100 milligrams. And the reason that 100 milligrams was chosen was efficacy against mutations such as G1202R and CNS activity. And that's particularly important in patients with disease that's refractory after prior second generation inhibitors. How important it is in the first line setting, I think, is less clear, where you don't have those mutations. And the data from dose reduction in CROWN suggests that both PFS and intracranial control are similar with 75 versus 100. But in practice, I tend to start still at 100 milligrams, with the exception of the patients that Justin described, the patients who might have less cognitive reserve, for example, the older patients, the patients with pre-existing psychiatric or mood comorbidities. But I have a super low threshold for reducing to 75 milligrams, and probably somewhere between a third and a half of patients end up having dose reductions, and often relatively early. And as we'll talk about, it's important to discuss the issue of CNS toxicity with not just the patient but also their families, so you get an accurate reflection and early reporting of what's going on there, so you do have a chance to intervene.
So yeah, and we'll get more into toxicity with your talk, Ben, but I was interested though in the pro-lorlatinib paper that was written at Ross in the journal there. I was surprised that the rates of dose holds and dose discontinuation didn't look that much. I was kind of after I read your paper, I was expecting to be way higher for lorlatinib. It kind of didn't seem very much higher, but I guess Ben's going to get more into detail there. But just to pin you down a little bit more, and Ross, you can comment on that as well, but just to pin you down in terms of practical decision making, I know you individualize it, Ross, but in general, do you tend to start with a second generation agent? Which one does it, is it usually, are you using brigatinib in any situations first line? And what about if they have brain mets?
So the first thing, so I actually start with alectinib, and I keep brigatinib if I know they have on-target resistance because I've rebiopsied them. I keep brigatinib as a next line, less toxic version of lorlatinib. In terms of brain metastases, as I said, I actually think these drugs are all very good in the brain, and so simply the presence of brain metastases doesn't push me to lorlatinib. When we go through the real life cases, I tried really hard to think of one situation where I would absolutely start with lorlatinib. So I think if you had a brain metastasis in a very critical part of the brain where you had no room for error, sort of that might be the situation. But generally speaking, the presence or absence of brain metastases doesn't influence my choice. But you're right, you raise a very interesting point in terms of the dose reduction rate in the trial was like 20%, 21, 22%, Ben probably knows. And yet, in Justin's most recent paper or with the Go-Go Jack, the CNS side effects was what, 60%, Justin? Something crazy high. And in the slide set that Ben showed, that was kind of running about 20, 30%. So I think we've got better at asking the questions. And as Ben mentioned, we're asking them to the spouse or the partner in addition to just the patient. And so, there's more toxicity going on than I think was captured in that paper. And Ben says his dose reduction rate is 50% as opposed to 20% in the trial.
I think it also raises the issue of even just when you compare, drug discontinuation rates among trials, it can be deceiving, right? Because it also, how the protocol is written, what labs are being drawn, because if you look at, ALEX, you look at Alta-1L, and you look at ceritinib studies, of those, actually ceritinib has the lowest drug discontinuation rate, but none of us would say that that's the easier drug, right? So I think you have to, put it in context that sometimes just drug discontinuation alone may not be the best metric.
I will say, one of the most common reactions we get to our work from oncologists in practice is kind of they like it when you struggle. Like this conversation they have, they will feel a lot of comfort in it because they feel like they don't know the answer, but you do. But then when they hear you kind of go back and forth like you just did, they feel a lot better. So anyhow, with that, I want to ask Solange to go through her topic.
Thanks so much. I would like to start first reminding the paradigm of this amazingly long survivorship we were able to reach by sequencing treatment in the context of ALK-positive non-small cell lung cancer. And that's what I'd like to addressing the question of resistance is how to best sequence this treatment in order to have an additional accumulative life which is the longest as possible. And this slide, just to remember to everyone that two of the important paradigms are the young age of these patients, the never smoker habit and the young age, and also the risk for the brain. We can diverge on the mechanism which are involved. I still believe that progression in the brain or emergence of new lesions respond to the same mechanistic phenomenon and the same response to the drug, but that's the paradigm of ALK-positive disease. So when you think about sequencing, we already have seen many data presented by Ben, for example, before, showing that what we measure usually is PFS. But is PFS exactly what we want to know? Because what we want to know is maybe not what you get with only one drug, but what we get using one drug after another drug up to the point you are exhausting other solutions. So the sequencing is probably as important as the individual activity of each of the compounds. So we have still, and that's a gray zone, to define the best way to sequence, to stratify our treatment, knowing that we have more than one accessible. So if you look at this individual PFS, of course, lorlatinib is from far the best today. The question is, how far are you going down the line by having a sequencing strategy? PFS might not be the optimal endpoint in the perspective of treatment sequencing, particularly in ALK, but in many other diseases too. One of the examples I was quoted before is the JALX trial. In the JALX trial, there was a very strong crossover after randomization of alectinib versus crizotinib to, again, alectinib or to a next generation TKI. And if you do so, suddenly you delete, you obliterate your overall survival benefit, meaning that sometimes sequencing can be as good as starting with the new compound. So we have really to keep it in mind. And what is probably more important is if you sequence, is to be successful in sequencing, meaning that you have to expose the patient who might not really have received one compound to these compounds later on. This is about the sequencing will be defined by the identification or at least the understanding of the mechanism of resistance to TKIs. So as it was described before, there is all this paradigm of secondarily mutated ALK proteins, acquired resistance mutation in the ALK gene, which is to modified ALK protein. It's called an ALK-dependent mechanism of resistance. Sometimes ALK-dependent mechanism of resistance can also encompass some level of amplification of ALK. But this is still about ALK. So if it is the case, you'd like to stay on an ALK-targeted therapy if you can. And you have this big paradigm of bypass tracks, other alternative pathways, which can, of course, be met, but can also be, we have been seeing that, KRAS, some epithelial to mesenchymal transition, sometimes histological subtypes to small cell, so everything which is not ALK-dependent. Thinking about ALK-dependent, the right panel here on the slide, if you look at the slide, it's just telling you one thing. The ALK-dependent mechanism was quite rare using crizotinib frontline, 20%. But now when we use new generation ALK inhibitors, the ALK-dependent mechanism, the mechanism of resistance dependent on the modification of the ALK protein, is way more often encountered. You can look at it for each of the drug, right? And you can see that up to 50%, even 60, 70% of these resistant tumors depend on a new ALK mutation. When you use ceritinib, alectinib, brigatinib, and for example, when you use lorlatinib, more than half or at least half of these tumors depend on an ALK mechanism of resistance. What is interesting when you look at lorlatinib resistance, it can be dependent on ALK, but very often that's what we probably like. So mechanism of resistance, ALK-dependent mechanism of resistance, does not only require one mutation for resistance, but two mutations for resistance, meaning maybe in terms of biology and selection, the clonal selection, it might be slightly longer or more difficult to reach for a tumor to accumulate dual compound mutation to resist a drug. Of course, one paradigm not to forget, we know it from EGFR, is what to do in any type of resistance if you have, I would say, an oligoprogression. So a progression which can be counted, 1, 2 new lesion, 1 or 2 new lymph node, something which looks tiny, but objectively progressing. So both guidelines, ESMO guidelines, NCCN guidelines, and all the others still propose to potentially try to grab the best benefit on the drug you have on board. So try to operate, but more often irradiate the oligo progression and continue the drug. In EGFR, we have been showing it can be 3 months, 4 months, 5 months more under your drug. In ALK, sometimes, I wonder what my colleagues have observed, it can even be way more, 1 year or 2 more years, particularly when it's about the brain. So a hope for some additional months on the line that I have shown initially. Then if you have an ALK-dependent mechanism, it becomes the tricky part. You have this kind of tables, which are in vitro assays, kinetic activities, which are looking at each of the secondary mutation and the potential activity of drugs. And that's where I meet my friend Ross Camidge about lorlatinib in second line. If one drug is able to potentially target all these known secondary mutations acquired in the frontline setting, this is lorlatinib. Lorlatinib is good in targeting this resistance mutation. So that's maybe why it's also positive to keep it for second line. There are many small trials looking at activity of TKI after TKI. You can see here that after alectinib, after second generation TKIs, some drugs have been tested, seritinib, brigatinib, benzartinib, lorlatinib, with a response rate, very variable, but more or less, I would say between 25 and 35%. So there's really about the heterogeneity of the mechanism of resistance, small series, showing that at best, this remains probably better than chemotherapy. And probably the most established of these trials is a phase 1/2 trial of lorlatinib, where 110 patients have been treated with lorlatinib after alectinib, seritinib, brigatinib, showing this response rate of 35 to 40%. So lorlatinib is probably the best established after a TKI. And it's nice to see that it is established in the context of an ALK-dependent mechanism of resistance. The mutation is detected. If it is the case, you can go up 60% response rate to lorlatinib. And if you don't have a resistance in ALK, if you have an ALK independent mechanism of resistance, it was nice to see that up to 30% of the patients were still responding. Remember my previous slide? It means that even if you don't know, because sometimes you don't know, or if you don't have an ALK-dependent mechanism, lorlatinib is still in second line, probably as good as chemo. And I must say, usually the patient prefer to stay on a drug, oral drug, which is targeted, and keep the chemo maybe for later on, set move him to chemo here. So here again, I join Ross in telling that maybe the argument for lorlatinib to me is that it's a good drug in second line, even if you are blind to the mechanism of resistance, okay? Of course, the main illustration maybe of lorlatinib in that setting is when you know the mechanism of resistance and you have to meet this super tough resistant mutation, the most difficult to address, which is called G1202R. This mutation is found in up to a fourth or a third of the patient after new generation TKI. And what was very nice was to show that lorlatinib in G1202R, the tough mutation, response rate to lorlatinib is 60%. So really a drug which can be used second line. And again, as I said before, to resist to lorlatinib, you need compound mutations, which might be difficult to acquire for the tumor. But what we don't know is such a dual mutated tumor very aggressive? We still don't know today. It might be another biology too. What do we have as drug to overcome compound mutations met after lorlatinib resistance? You can see some of these compound mutations, don't remember their name, but what you need to remember is the red table on the right, meaning that today, when you have a compound mutations after lorlatinib, there's nothing we have which really works. So that's quite important to say that here, it's the difficulty is what to do when you go back to the old days. Chemotherapy, radiotherapy, if you can do, sometimes immunotherapy. So you go back to the non-personalized, non-precision oncology. Here we have one trial which is always quoted, the IAM Power 150. In that trial, patients were directed to a treatment with atezolizumab, bevacizumab, and chemo versus bevacizumab chemo. In this 4-arm regimen, EGFR patients were doing surprisingly well. In that trial, there were some patients with ALK. Altogether, there were 34% with ALK alterations. But based on that, the result of this trial was potentially considered showing a role for immunotherapy, bevacizumab and chemo in these never smoker patient with EGFR or ALK. I'm still not convinced, but some will use based on these 34 patients in this trial. I would rather think about something different because in IM Power 150, it's paclitaxel and carboplatin. What we know since a long time, maybe 10 years, that's the activity of pemetrexed in ALK-positive disease, probably due to the thymidine synthetase, which is overexpressed in ALK-positive disease. And as you can see here, a long duration of response and a nice PFS and response rate is related to pemetrexed-based chemotherapy. So maybe that would be my favorite option when it's time to go to chemotherapy. IO is not really documented formally in ALK, but everything we have is showing no response. Not reported, but also no response to monotherapy IO in ALK-positive disease. So that's probably not really the way to move today. Some have tried to combine ceritinib, lorlatinib, alectinib, or even crizotinib to immunotherapy. And the conclusion is for the combinations which are tolerable, is it we do not really observe an additional benefit of having IO in addition to the targeted therapy. This is true for ceritinib, lorlatinib, and alectinib. And sometimes this is not doable, for example, for crizotinib and nivolumab with a high rate of toxicity. If I remember well, it was hepatic toxicity, liver toxicities. So sometimes it's not feasible, but would it be feasible? It doesn't look to be beneficial. So not really a room for immunotherapy here. Maybe what's next? We have fourth generation inhibitors, NVL-655, TPX-0131, which are highly CNS penetrant and active against compound mutations. So the red table becomes a little green. So maybe this will come when you have compound mutations, but we still need a little more data. And of course, we try vaccine, we try modification of the T-cell receptors, we try an antibody-drug conjugate, and we try fancy combination with MEK inhibitors, SHP2 inhibitor, mTOR inhibition, but all of these are experimental and might tomorrow give us some insights in new strategies, but they are part of clinical trials today. So I think you know everything about resistance today. Remember the graph. The question is not so much how to really start, but the question is how long are you going to last by sequencing treatment in ALK-positive disease. The last line is a great one published by Lin and Shaw, just trying to really make first one difference, the oligoprogression. Consider local ablative therapy. Really something we forget, but I would say stereotactic radiation is now simple to do and has made so much advances that we have to recognize something to the radiation oncologist. Stereotactic radiation is an amazing advance in the field of lung cancer. And if you have a systemic progression, if you can, look at the resistance mechanism and target accordingly. ALK-dependent resistance, you have my nice colorful table. ALK-independent mechanism, you can still use lorlatinib, but you can also move to combinations, clinical trials of course, chemotherapy.
That was awesome. Thank you so much. I was just flashing on something again back. I'm sure oncologists always are thinking about other cancers. But Justin, they have a thing when Solange went through the idea of oligoprogression, in breast cancer, specifically in HER2 positive disease, where we do have some CNS drugs, or at least that get in there that respond, they have sort of an algorithm that if the patient is responding systemically, but then progresses just in the brain, to treat the brain locally, like with radiation, and then keep the same systemic therapy going. Would you think that that paradigm applies, say, to ALK?
Absolutely. I think using local ablative therapy, especially if someone's been on drug for a long time, tolerating therapy well, I've done that a number of times, and even I've had a number of patients long-term on alectinib progress in the brain. We do local ablation therapy, then they progress again. The other thing that we haven't talked about that is an option there is, remembering that 600 milligrams BID of alectinib isn't an MTD, and so we've even dose escalated beyond that based on some of the doses used in the phase 1. Obviously, that's off label, but in someone who had been on the drug for we were just at tumor board, someone who'd been on alectinib since 2015, progressed in the brain, did surgery and radiation, now progressing again, was tolerating drug great. Yes, we could go to lorlatinib, but consideration of dose escalation there. So that is something that, again, that isn't an approved dose, but it is something that we've done and published on.
That's interesting. I remember hearing about that with osimertinib, but I didn't realize that even been looked at with ALK. Okay, well, let's finish the presentation section with Ben, who's going to review toxicities with ALK inhibitors. Ben?
Thanks very much, Neil. So I think as we've heard throughout this session, that we've had the development of multiple new ALK inhibitors, and they are, as we saw from Justin, structurally different. They're different chemically. The newer ones tend to be more potent against ALK. They've got better mutation coverage and better CNS penetration. But what's also important to appreciate is that they do have different toxicity profiles. And when we're prescribing these drugs, we need to be aware of these toxicity profiles and, importantly, how to manage them. So we've learned from the clinical trials that there is some overlap with the agents in terms of toxicity profile. But perhaps more remarkably, in drugs that are all in the same class, we do see some very distinct side effects. And I think it is worth digging a little bit deeper into what these side effects are and how to manage them. So, as I mentioned, we've got a large number of ALK inhibitors that are approved for clinical use, but I'm going to focus on the three that we tend to use in daily practice, and alectinib, brigatinib, and lorlatinib. But I will mention that with some of the earlier ALK inhibitors, crizotinib and ceritinib, we became aware of distinct toxicities which aren't necessarily related to on-target inhibition. With crizotinib, we learned about visual side effects which were related to dark to light transition. And what we learned was that we ignore these side effects. They have no consequence on patients. And with ceritinib, we experienced very significant gastrointestinal toxicities. But we learned that these were manageable with giving the medication at a reduced dose and with food. So knowledge about how to manage toxicities has been important in being able to deliver these drugs. So let's focus on the ALK inhibitors that are in clinical practice for first-line treatment. So let's start with alectinib. So alectinib is given at a dose of 600 milligrams twice daily. It comes in 150 milligram capsules. So this is 8 tablets a day. So it's quite a significant dose for patients, and when patients come to clinic and take their month's worth of alectinib home, they have to bring a pretty big box or take home a pretty big box with the medications. It is well tolerated, but we do see common side effects, and these are important to tell patients about, and include constipation, fatigue, edema, myalgia, and anemia. So important to let patients know that these can occur and to be proactive about managing them. I will make mention of some of the side effects, and I'll start with myalgia. This is common. It occurs in close to 20% of patients. In most patients, it's mild, and a patient may tell you that they notice after they exercise that their muscles are more sore than usual. But in some patients, it can be more significant, and they can have myalgia at rest, and this can be associated with elevations of creatinine kinase. And in these situations, patients do need to have dose interruption and often dose reduction. You can try re-challenging at the same dose, but you often see that myalgia comes back. And in this, for this reason, monitoring CK is part of the monitoring process, as I'll mention. Another thing to be aware of is anemia. Mild anemia you'll often see on when you do full blood examinations on these patients. Hemolytic anemia can occur, but is uncommon. But I think something that docs prescribing alectinib need to be aware of is pretty much every patient who's on alectinib will have really funky looking red blood cells on a blood smear. So it's I've had phone calls from hematologists, hematology labs about, do you know that your patient has these strange looking red blood cells? And I say, and I've learned to say, yes, I know. And that's because they're on alectinib, and you can ignore that. And then finally, again, another thing to be aware of is changes in liver function tests, transaminases and bilirubin. And you will often see patients on alectinib who have mild elevations of bilirubin in the absence even of transaminase changes. And again, that in isolation is something that can just be observed. So as a consequence, the sort of monitoring process for alectinib includes liver function tests and creatinine kinase, and it's recommended that the creatinine kinase be tested 2 weeks after starting. So in practice, what I do is when I start patient on alectinib, I describe these side effects. I schedule either a visit or a phone call in 2 weeks' time at just at the time they have their blood test, but really just to monitor how they're going with the medication. And I do this essentially with all the TKIs that I start, have this sort of early follow-up, which has been made easier to schedule with telehealth. Now, brigatinib is the second ALK inhibitor, which we'll talk about. So the dosing here is a bit different. There's an initial dose of 90 milligrams to start with for a week. And then if patients tolerate it well without respiratory symptoms in particular, the dose is increased to 180 milligrams. So the common side effects reported with brigatinib are diarrhea, fatigue, nausea, rash, cough, myalgias, headache, hypertension, vomiting, and dyspnea. So there are a range of side effects. The ones to be aware of and that are distinct to this pulmonary symptom, and I'm not sure, and Ross has had a lot of experience with brigatinib studies. I'm not sure ILD or pneumonitis really is the right term to describe this. This is a constellation of respiratory symptoms, shortness of breath or cough that can occur early, typically in the first week of treatment. And this was seen particularly in patients that started at the dose of 180 milligrams. And starting at 90 milligrams with this sort of step-up dosing regimen really does seem to reduce the frequency of this pulmonary syndrome. So cardiovascular side effects can be seen, including hypertension and bradycardia. Again, biochemical abnormalities can be noted, CK elevation, pancreatic enzyme elevation, or hyperglycemia. Mostly these tend to be biochemical without need to change dose clinically. So the recommended monitoring is, again, an early review. In the case of brigatinib with the pulmonary toxicity, I think a little bit earlier at the end of week 1 or 2, and then monthly. Now, lorlatinib, I'll speak to next. So lorlatinib, the starting dose is 100 milligrams, and dosing is important. Now, this really does have a distinct side effect profile from the other inhibitors. And I've shown here the toxicity profile from the CROWN study showing the frequency of the different adverse events. The most commonly reported ones are elevation of lipids, both cholesterol and triglycerides. Other side effects that are seen are edema, weight gain, peripheral neuropathy, and importantly, cognitive effects. And this side effect profile is unique to lorlatinib, and as we'll discuss, does require proactive management, including dose reduction. So firstly, I'll mention hypercholesterolemia. This is really common, occurs in 60 to 80% of patients. Interestingly, this does not seem to be associated with an increase in cardiovascular adverse events in either the phase 1/2 trial or in Crown study, with the caveat that follow-up is obviously short in these studies. But this does seem to be different to the implications of raised cholesterol in the context of, for example, metabolic syndrome, and it is an isolated elevation. Now, there are certain specific statins that are recommended, rosuvastatin, pravastatin, and pitavastatin. And the reason for that is some other statins, such as simvastatin, have their metabolism affected by lorlatinib. So it's important to use these statins, and oftentimes you need to use a slightly higher dose of the statins. For triglycerides, fibrates, and not gemfibrozil are recommended. Now, the CNS effects are probably the most important to talk about. They occur at a frequency, we talked about this earlier in the trial, the frequency of CNS adverse events was about 30%, 35%. In the series from Mass General, it was a little bit over 50%. So they have a spectrum here. This can be changes in cognitive function, mood, speech, and very rarely psychotic events such as hallucinations. Now, the cognitive effects can be things like forgetfulness, missing a train stop or a tram stop, for example. The mood effects can range from the typical thing seen here is emotional lability. So a patient may burst into tears watching a movie that wouldn't normally make them cry, or looking at photos. The speech effect is typically slowed speech. For most people, they're mild, but importantly, they resolve with dose interruption and tend not to recur with dose reduction. So I think it's really important to tell patients and the people who look after them about the possibility of these effects, describe what they are, mood, speech, and instruct the patients and the caregivers to report them when they occur. It's important to have a low threshold for dose interruption and dose reduction. From people doing clinical trials, we're sort of told to persist through grade 1 or 2 toxicity and only interrupt when it gets to grade 3. But I think in the case of these toxicities, even for mild toxicity or grade 1, I would interrupt dose and reduce dose. So hence the frequency of dose reduction we talked about earlier. Now, the risk factors, I think the paper from Justin's group really looked at this in quite a bit of detail. It is hard to predict, but factors such as prior brain radiotherapy, pre-existing psychiatric disorders, and the use of neurotropic medications have been associated with an increased risk of the CNS effects. And this is the paper from Dr. Dagogo Jack. So, but I think what's really important to get across is that dose reduction is effective in reducing these toxicities and does not seem to be associated with reduced efficacy. This is a plot of PFS in patients who had dose reductions compared to patients who don't. All the caveats of the small numbers, but there doesn't seem to be an effect on PFS. And I haven't shown here, but we've also got similar data looking at time to intracranial progression. And patients who have dose reductions from 100 milligrams to 75 milligrams do just as well in the brain as patients who don't have dose reductions. So I think it's important to be proactive about managing toxicities, tell patients and their caregivers about side effects, have early and proactive dose reductions.
That's great. Thank you so much, Ben. And for those in the audience who want to know what fortnightly is, which I didn't know, it's every 2 weeks. We don't all know. Fortnight, I never heard, wasn't sure about that one. So Solange, just kind of curious, how aggressive are you about dealing with the hyperlipidemia? You know, Ben mentioned the fact it doesn't seem to relate to cardiac disease. Of these people have an incurable illness. Why even treat, and how aggressive are you treating?
Yes, we have been, and I'm looking forward to see what my colleagues have been adopting in terms of strategy. We've been pretty conservative in trying to treat hypercholesterolemia. Of course, the data tell us that there were no major events at the cardiovascular level which have been reported on, but also because probably initially in the very early days of lorlatinib, and maybe in many centers still now, we try to treat hypercholesterolemia. So we don't let the cholesterol double, triple, multiply by 10 without any intervention. The other thing which is important to keep in mind, maybe to moderate this, these patients are not the heavy smokers, elderly patients that we usually see with lung cancer. So they are not the usual subjects for strokes, cardiovascular event, infarcts, and so on, because at least they don't have the smoking habit story, right? And they might not have the hypertension of the age. So what I mean by that is they might have family history maybe, but cholesterol are the only factor. But still, remember that it might be at the end of the crown story, years under lorlatinib. So what does it mean for a vessel to be exposed to an increased 3, 4, 5 times of cholesterol for 4 or 5 years? I wouldn't bet about it. So I'm pretty conservative. I know giving statins is not easy. Sometimes you have to change the drugs, change the strategy, negotiate with the patient. Sometimes you can't negotiate with the patient. But if you can, I would still be conservative and treat hypercholesterolemia. It's about the basis of internal medicine to me. But of course, this will deserve additional data in the future with a long-term outcome of lorlatinib.
I want to ask Justin, I'm curious what you say to your patients who are about to begin lorlatinib, particularly in terms of, you know, you were mentioning talking to the family, et cetera. I mean, you don't want to scare people. On the other hand, it sounds like they're going to be pretty important in terms of detecting. How much detail do you go into? How do you actually explain to people what to look for?
It's a great question. So I do go into a lot of depth with my patients when I'm starting. I do also think it's important to talk to them about the time course of some of these side effects, right? Because they vary. So for the neurocognitive effects and mood effects, those tend to occur early. You know, it's not like you're going to see it a year into therapy. You're generally going to see it a couple weeks in to therapy. So I do paint the picture of, you know, and like Ben mentioned, you know, I do make sure that, you know, the spouse or whoever's living with them hears it as well. And it can be really subtle, as simple as, you know, feeling like you had an extra cocktail, to a little slowing, to just irritability. You know, one person was just yelling at the dog, like that was the sign, and they didn't have self-insight into it, right? So recognizing that it's subtle, you know, just it can be subtle, it can be more profound, it occurs earlier when it comes to the neurocognitive mood issues, and then really emphasizing that alert us to it, because, you know, very low threshold to hold. My experience has been it universally improves with drug hold and then dose reduction. So I think underscoring this is not something that just tough it out and push through. You know, our goal is to have you on this drug for years and years and years, and we can't have you upsetting everyone else in your life, right? So you know, I find, you know, that's an easier thing to counsel patients on. Even the cholesterol, I think, is easier to counsel on. What I struggle with is honestly the weight gain, which isn't unique to lorlatinib. We see that with alectinib too, and that's one of those things that, you know, years on therapies, see potentially gradually increasing weight, and that's not a simple thing to just hold drug, right? And it instantly gets better. So I do, counsel patients on that, but that's a harder toxicity to manage.
I think I recall a case I heard when lorlatinib came out where the spouse actually liked the patient better on her lorlatinib. Anyhow, I don't know how often that happens. Solange?
I had this patient. I had a very nice patient, extremely depressed since the age of 15 years old, who got an ALK-positive disease when she was 35 or something like that. And the drug was giving her a little more aggressive mood, like irritative mood, but she liked it because it made her way more reactive to life around, but she must be the only one. I just wanted to stress how subtle it can be sometimes. That's why you need really to explain. I had this wonderful businessman who was just telling me, if you really looked for it, right, how he irritated he could be about everything around, right? A kid in the street, right? In the tube, the people around. So if you don't ask, people sometimes feel guilty because they think it's about a bad diagnosis, cancer, and everything which comes with the fact of suffering from advanced cancer, right? And it can just be the drug. So it's also a little about kind of removing a guiltiness that they might have, having new feelings which they might attribute to cancer diagnosis and coping. Sometimes it's just the drug is not coping.
Really interesting. So let's see if we can get through a few of these cases. And incidentally, regarding the issue of younger patients, if you look at the list of your patients here, there's only one of them that's over 65. You have a 32-year-old, a 40-year-old, 48-year-old. Interesting profile. So Justin, let's start out with your 40-year-old lady. What happened with her?
Yeah, and in fact, I actually saw her 3 or 4 hours ago. So this is a 40-year-old lady I met in 2017. Light smoking history, 5-pack years, had already quit. History of depression, anxiety, and obesity. Who presented outside hospital, like many of our patients with lung cancer, with persistent cough despite multiple antibiotics. Ultimately had a chest x-ray, showed a right upper lung zone opacity. Follow-up CT showed a 4.8 centimeter right upper lobe lung mass with ipsilateral hilar and paratracheal adenopathy. You could see the PET there, which shows both hilar, paratracheal, and she had ipsilateral supraclavicular adenopathy as well. Had EBUS. We had a conversation at the time, she's young, supraclavicular adenopathy, stage IIIB disease, tough to cure at the time, but we did pursue definitive chemoradiation. She completed it. And then we had the conversation that we were having earlier in this session, which is, what do we do when it comes to consolidation therapy? This was in 2018. Durva was approved in February of that year, but we had already seen the subgroup analysis. So we talked about Durva versus ALK TKI versus observation. Ultimately, we opted for observation. I thought it was a big field, and I was reluctant to pursue ALK TKI off trial. Unfortunately for this patient, a short time later developed had persistent disease, which we did repeat biopsy to confirm that had persistent disease. And she started on alectinib now over 4 years ago, and scans today continue to look great. So she's having an ongoing response.
And what's been her status in terms of quality of life? Any toxicity or side effects?
Yeah, so she had some mild myalgias, but that wasn't too problematic. Her big issue has been weight gain. So she did have a history of obesity even starting drug, and she has struggled with weight on alectinib now, having been on it over 4 years. So working with a dietitian, personal trainer, trying to keep her weight down.
Ross, any suggestions? I love that intro about your clinic and the philosophy behind it. We put that in the slide deck. What about complementary strategies for these people gaining weight? Justin mentioned nutritionist, I guess exercise physiology. How do you approach anything work for these patients? You know, you have these new injectables that are out there once a week. Have you tried that? What's your approach, Ross?
So I have to be honest, I feel in oncology, our expansion into general medicine keeps continuing. So we learned about how to manage cholesterol. I haven't learned how to manage weight separately from the kind of basics, but I think the key thing is education at the beginning. Just as you're trying to tell the patient that they and their mood and other things might alter, you have to say you're going to be more prone to put on weight. And again, we become victims of our own success. If they stay on these longer, it can go up. So there are 5 of us on this call. One of us would put on 20% of our body weight if we went on lorlatinib. So it's a 20% put on 20% of their body weight. So it's a big deal. It also happens with alectinib, as in this case. But I think you just have to warn people. And, I don't know if it's been written up, but I'm sure we all have the same experience, just like with the neuropsychiatric ones, that people who have weight gain issues to begin with are the ones who are more likely to have weight gain issues when you go on these drugs.
All right. Ben, you have a 54-year-old woman, a never smoker. What happened with her?
Yeah, so 54-year-old never smoker, mother of three children, including one with special needs, who presented with bone pain, fatigue, and weight loss. She had a mass in her lung and metastases to her liver and bone, but not brain. A biopsy showed an adenocarcinoma consistent with a lung primary, and this was positive for ALK by immunohistochemistry and FISH. So in terms of choices for initial therapy, we had available alectinib, but we did happen to have a first-line trial with lorlatinib. So she commenced lorlatinib at a dose of 100 milligrams every day. She had an excellent response to treatment, a complete response to treatment. But she did have some toxicities that needed management. She had elevation of her cholesterol, which we noted at 1 month after starting treatment, and she commenced rosuvastatin at a dose of 20 milligrams with good control. She also, and we talked about this earlier in terms of mild toxicity. She is a lovely, easygoing lady, but she noticed that she was getting a little bit more irritable with her kids. Things that they did which she would just let pass, she would feel herself getting annoyed about. So for that reason, we reduced her dose from 100 milligrams to 75 milligrams now nearly 4 years ago. And she's tolerated it well. Her relationship with her family and kids is great. And she continues to remain free of disease and importantly, free of brain metastases.
Ross, any comments about this case? And also, I don't know if we're going to get to it, but I know you've written about, and I think you have one of the cases that relate to the issue of surveillance in these patients. Can you comment a little bit on that? And also the issue of CNS surveillance.
Yeah, I mean, we should really ask Ben how he's been tracking this patient. But I think what you're trying to do, I think, as Solange mentioned, is we're trying to really catch not just progression, but oligoprogression. And, I think we have to start to question what is the best way to do that, because then we have radiotherapy as this additional kind of extending out your initial treatment. So Ben, how do you actually follow this lady?
So the initial follow-up was sort of mandated by the clinical trial, so that's sort of a little bit more intensive than we would usually do. But typically I would do scans. I think the first scan I would tend to do earlier, so about after 2 months. But following that, I'd do 3 monthly scans. And again, with the point that you raised about the possibility of intervening early with CNS disease, I would try to do an MRI scan as part of the surveillance. So
the frequency of brain scans in those with and without baseline brain metastases, how do you do it?
Good question. Look, I think I do it at a similar interval. I think the sort of difference is that MRIs can be a little bit more tricky to access, and I might alternate scans with a CT just because of availability, not because of preference in the patients without brain metastases. But in both situations, we know new brain metastases can occur. I guess in the setting of prior brain metastases, there's also the situation of pre-existing brain metastases getting worse. What do you do different, Ross?
So I think for patients with brain metastases, I think it's another side of the disease. So I'd do the same as you and scan at the same frequency as the body, access issues aside. I think for patients who don't have baseline brain metastases, some of these drugs are so good. I initially went to every 6 months, and for some patients, I'm just doing annual. But I wonder what my colleagues do.
Solange?
Same thing for patients with brain mets. Of course, you can try to match the MRI ideally because the new lesions can be small. MRIs with the CT scan. Like Ross, I go more or less halfway. In patients without brain mets, I usually do CT scan every 3 months, but MRI of the brain every 6, also for a question of availability.
Justin, how do you approach it? And what do you say if the patient says, am I cured?
For the scanning issue, if baseline brain metastasis is like everyone else, I will just every 3 months continue it. If they're on a CNS penetrant ALK TKI, I'll generally extend it to every 6 months. In terms of the curability question for TKIs, I say no. These can provide long-term, disease control that can be years, but we don't think by TKI alone we can cure this disease. IO, it's a completely different thing. I do think we are curing some of our lung cancer patients with IO, but as we've said before, these tumors are not responsive to IO monotherapy.
So there's always the time capsule too. Let's not forget about that. I did a video about a month ago with a patient who I was mentioning that they just got their first bispecifics approved in myeloma. I did a video of a patient who had been on that bispecific for a year and a half because of the trial, the same as Ben's patient. It really gets into the advantages of clinical trial participation, something that we're really interested in. All right, let's do another case here. Solange, you have a 61-year-old woman. What happened with her? Former smoker.
Yeah, so she's first of all betraying our intuition because she was a former smoker, heavy smoker. So the first thing you think is not an oncogene addiction. No comorbidities apart from the smoking habit, a PS of 1, and she was a working girl, right? Very successful engineer in life, very active, super busy. Diagnosed quite late because she has let the symptoms evolve with lung adenocarcinoma, unfortunately already a stage 4, mediastinal lymph nodes, liver mets, bone mets, no brain mets at initial diagnosis. The molecular testing was identifying a translocation, a variant 1 of translocation. And again, don't look at it, but we always look at it's kind of a reflex testing. The PD-L1 is 10%, but as you understood before, it will not help you in your treatment decision. And you can see on the slide the images of a pretty large tumor, right, in this patient. She was treated. That's the charm of Switzerland. And here we are in 2019. Now we are not in 2015. But in Switzerland, we have this charm of having still, I don't know about US, but we have still private oncologists who treat one day glioblastoma in breast and prostate and lung and GI all together, with a little problem of course, being able to, if you don't look at transmissions like yours, the problem is you might miss something. She went on the crizotinib, which we probably consider now as being the wrong answer. It was in private practice. She had a good partial response. Unfortunately, it lasted for 12 months. Not bad. So, well, anyway, she came to me, of course, when it didn't work anymore, with at the follow-up on this maintenance of crizotinib. She has complaints of headache, dizziness, and as you can see, a kind of a terrible brain scan, which needed dexamethasone because of the volume and the edema around. Interestingly, It was less. It was also progressing at the systemic level, but not so much, not as much at the brain level, due to the, of course, a story of crizotinib. She received at that time lorlatinib. I think it was a good indication due to a huge brain lesion at my hospital. And the treatment tolerance was mediocre because she couldn't work anymore. She was irritable, but she was telling, very interestingly, that she was forgetting very important elements when she was presenting the charts, right? So she was forgetting the important thing she had to think about was escaping at the last minute, right? So for an engineer, it was a problem. She achieved a very good partial response at 6 weeks, a progressive shrinkage of all of the lesion, and almost a complete response at 4 months. The problem she had was still this mood and cognitive dysfunction, where I had to reduce to 75. She could still not work, 50 milligrams, and it went better. But still, she didn't really appreciate everything of that. And she also got 4 kilos more. She had a hypercholesterolemia. It could not tolerate statins, so a difficult thing. So basically, at 50 milligrams, it improved progressively. However, at some assessment, maybe 4 months later on, she was progressing on the 50 milligrams, right? Lung, bone, liver, she was progressing, not in the brain, but everywhere else, as you can see here. So it was the time we decided to move to chemo and IO discussion. We can discuss with the colleagues, which she tolerated well, good partial response after 6 weeks. However, she started to cough. So we decided to do, again, a CT scan, and she's not a very lucky patient, right? She got this pneumonitis under the immunotherapy, right? So what would you do? Lorlatinib was not tolerable. The lower dose was not allowing control of the disease. She's intolerant to IO. Responded to chemo. She got 4 cycles, but after maintenance pemetrexed, she progresses in the liver. So what I decided to go back to alectinib, and now I have seen her maybe just before Christmas. She's under alectinib for 9 months with a very good partial response and no brain relapse. So that's where I ended with this patient. So a strange sequence, but still now she's in good control.
Wow, what a story. I'd like to read that book. Ben, any thoughts about this case? Would you have managed it? Have you seen responses at 50 milligrams, incidentally?
We have, and we've seen. So one really interesting. Justin will speak to this, but when the lorlatinib phase 1 study was started, responses were seen at the very first dose level. I remember Alice Shaw telling me about a patient who responded at the very first dose level, which might have been 10 milligrams. But I think, as Solange was saying, this patient had a pretty tough time with lorlatinib. We have looked at post-lorlatinib treatment in the clinical trial, and we have seen that patients who've stopped lorlatinib due to toxicity issues have responded to drugs like alectinib and brigatinib. This is a little bit different because of the progression. And I guess a confounding factor may be the intervening treatment. However, the durability of the response is really encouraging.
All right, so let's go on to another case. Ross, maybe with this case, you can also elaborate a little bit more and demonstrate a little bit more what your thoughts are about the issue of surveillance. What happened with this 67-year-old woman?
Yeah, so I chose this case to go back to what I said earlier, which is, is our goal of surveillance moving from just detecting progression to detecting oligoprogression so that we can actually use local ablative therapies to do it? And so this is a 67-year-old Caucasian female, 10-pack-year smoking history, quit 30-odd years ago. And she presents, in this case, with shortness of breath, which turned out to be due to cardiac tamponade. And we know that ALK-positive disease actually has a predisposition to spreading to the pericardium. And indeed, that's what the fluid was drained. There was adenocarcinoma there, but insufficient for molecular testing. She had a full staging. Her brain was clear. She had a pleural effusion as well, a right hilar mass and a right supraclavicular fossa node lighting up on the PET scan. In an outside hospital, she was started on carboplatin, pemetrexed, and pembrolizumab. So this would be a great example where they didn't push for the molecular testing because they said they'd sort of done it from the pericardiocentesis, but there was insufficient cells there. So, and then she sort of came to see us, and we did biopsy that supraclavicular fossa lymph node, and she was ALK positive. on Solange's point, she had very high PD-L1, but we just ignored that. It was originally done by immunohistochemistry, and we confirmed that by next generation sequencing that she was ALK positive. At that point in time, various other things were happening. She was going back and forth between different hospitals. She had a right lung irradiated, and then they started her on alectinib about a month after the lung irradiation, and she got full-blown pneumonitis. Now, of course, the question is, did she get pneumonitis from the radiation? Did she get it from the alectinib? Was there a contribution of the components? But the alectinib was stopped, steroids were given, and everything settles down. And then she actually decides to move to Colorado full-time, and I sort of take over her care. We talked earlier about, where's the value of brigatinib? Well, it's very similar to alectinib in terms of other things. It has a slightly different toxicity profile. But she hadn't progressed on the alectinib, she just got this pneumonitis. We could have re-challenged her with the alectinib, but instead we just said, well, we'll try the brigatinib, even despite that early onset pulmonary events that happen in a tiny fraction of people. She had no problems at all. She went on the brigatinib, responded beautifully. And at this point of time, I started to introduce the idea of what we're looking for in terms of surveillance. So she's getting those same kind of standard 3-month CT scans that we all talked about. She doesn't have brain metastases, so she's getting an annual MRI brain. She's quite claustrophobic. But this is where the nuance comes in. So we know that a PET scan is very good at picking up lymph nodes and bone disease that you might miss on a CT scan. But insurance is freak out if you do it all the time. There's more cost, there's more radiation. And so what I do is I check blood-based tumor markers, CEA, CA125, CA199, and CA2729, at the same time as I do the scans. And whilst her scans all said they were stable, her CEA started to consistently increase during 2022, went from 3.4 to 4.5 to 6. And all I'm doing with the tumor markers is trying to tell me if the CT is missing something. I'm not changing treatment on the basis of that. As they went up, I said, we need to do a PET scan. And lo and behold, she has an oligoprogressive focus in her left hip, which you would never see on a CT scan. We zapped it with SBRT, and the CEA falls back to the normal range. Now, you can say, is this all nonsense? Are we treating blood markers? Are we just treating the scans? Can I prove it matters? But if we believe that detecting oligoprogression is the right thing to do, if you're not going to do a PET scan every time, this for me is a cost-efficient way of telling me when the CT is missing something.
Before I ask Justin to comment, it is disturbing that this wasn't picked up initially. Did they do a liquid biopsy on her?
No, they did it. They took the pericardiocentesis.
Just the pericardium,
they said you've got adenocarcinoma, and they said there was nothing there, but actually it was an insufficient specimen. They misinterpreted insufficient for negative.
Also, I'm always admitting things that I can't tell if everybody else knows or not, but I haven't heard about the pericardial thing. How often do you see that? Is there anything different about it? Why is it that it goes to the pericardium?
Well, those are different questions, but so Bob Doble was the first author of that paper. It was probably about 2010, 2011. And again, it was the excitement that as we started to see fragmentation of lung cancer into different molecular subtypes, they had different natural histories. And so the pattern of metastatic disease at diagnosis is different. The pleural and pericardial disease tends to be higher with ALK-positive disease. It's not huge, but it's rare to begin with. And so, maybe it occurs, I can't remember, like 10 or 20% of people. We don't know the reason for it, but it opens a whole new field of research in terms of why does that driver oncogene change the biology of the cancer in terms of where it spreads.
Really interesting. So why don't we go on to another case? Justin, this is your patient, a 48-year-old woman, never smoker. What happened with her?
Yeah, actually, another patient I saw this morning. So it was ALK positive day. This was really an example of, when we talk about that Lazarus effect, like this is one of those cases where it was a 48-year-old woman. She was a never smoker, really didn't have much in the way of past medical history, hadn't really engaged in the medical system, however, and so she really was developing progressive right hip pain, had actually went to the point where she couldn't walk. She was pretty much stretcher bound from osseous metastases. She went to an outside hospital, which is where she started the workup. They did additional imaging, found a lung lesion, liver mets. They did a liver biopsy that showed lung adenocarcinoma, and she was an inpatient at the time. They started radiation to the right hip and then discharged her. And I distinctly remember her coming into clinic on the stretcher. She was still at rehab and comes to me. And, we sent off a rapid NGS platform, showed an ALK fusion. I started her on, this was 2018. I started her on first line alectinib. She had a dramatic improvement. I distinctly remember her then walking into the next clinic visit. So her performance status dramatically improved. A year into therapy, though, she started experiencing myalgias, which Ben had told us about. We tried holding and then re-challenging at the same dose and just came right back. So we dose reduced to 450 twice daily, had a continued response. And then by 2020, still having persistent myalgias, we dose reduced again. But despite that, they were really starting to impact her quality of life. So by late 2020, we said we have to stop, let's switch to a different agent. We had a long discussion about, do we switch to brigatinib? Do we switch to lorlatinib? We talked about myalgias can also be seen, with brigatinib versus lorlatinib. Ultimately, I started her on lorlatinib. I started at 75 milligrams here. I was nervous. She did have a history of some mild depression, and so that's why I started at 75 milligrams with the plans to dose escalate if she tolerated it well. Her scan showed an ongoing response, but emotional lability. Really, it was more so irritability. We held, symptoms completely resolved. We dose reduced to 50. And then 1 week later, she came into clinic with really profound worsening of her mood symptoms. We actually had to admit her that day. And so I said, okay, enough with lorlatinib. So, the challenge of this lady's had a persistent response, but it's, this is now an advantage. We have so many different ALK inhibitors, right? So then we started her on brigatinib, late 2020. Unfortunately, at day 3, she did develop some of the early onset pulmonary toxicity, cough, shortness of breath, and Ross's team has described this really well. We pushed through, and on day 8, we dose escalated to 180, and she was able to get through it. Those symptoms resolved, and scans today looked great. So she's continued to be on brigatinib 180 with an ongoing response.
So, Ross, any comments about this case? I was going to say before, when you were talking about the patient you put on brigatinib who'd had the pneumonitis before, that must have been kind of an interesting experience. What did you finally come up with in terms of the etiology? It always kind of sounded to me the way you were describing it, like some kind of allergic type, reaction as opposed to sort of a pneumonitis. What did you come up with, and any other thoughts about this case?
So Ben actually mentioned before that the terms ILD and pneumonitis is probably incorrect. And so we've used this term early onset pulmonary events. If they happen, I think they literally occur in the first 24 hours. And there's a bit of soft evidence it's actually a vasospasm in the lungs that then you get tachyphylaxis to and it resolves. And so that's why the lady who had the radiation pneumonitis, I didn't feel any issues with it. The one issue is if you already have compromised respiratory function and you get the vasospasm, you're closer to the edge. And when we did a study, DLCO actually drops in everybody for a short period of time. The ones who have symptoms are the ones who don't tolerate it. So my prior lady with pneumonitis had it all settled down on steroids. And so I think Justin did exactly the right thing here. Also, even though the prescribing guidelines are kind of like, if you get it, don't go up. You get tachyphylaxis, I think you can go up just easily. So I think that's what you did here, Justin, wasn't it?
Yeah.
All right, let's see if we can do one more case. Ben, you have a 32-year-old man.
Yeah,
Diagnosed
really.
in 2014. Wow.
That's right. So a young patient, and more than half of patients, or the median age of ALK rearrangements is 51. So half our patients are less than the age of 50, and I think we all have patients in their 20s and 30s. This is a young man, a 32-year-old never smoker who was diagnosed with metastatic ALK-positive lung cancer in 2014. He commenced first-line treatment with ceritinib then. He had an initial response to treatment which lasted for about 2 years. So, he did enter the time capsule, I guess, to an extent. But he had a pretty dramatic progression. He actually presented with seizures with rapid CNS progression. He was treated at another institution, but actually ended up in our emergency department. He had a CT scan shown here with these large brain mets with midline shift and with seizures. So he needed to go to urgent neurosurgery the night that he presented. He then went on to start lorlatinib at a dose of 100 milligrams, and had a complete response to treatment. So this young man's pretty remarkable. So we met him, actually, he was on the floor of the emergency department because they were worried about his seizures and the falls. He started on lorlatinib. We spoke about the Lazarus effect. He actually got married in a hospital a few days after starting lorlatinib because of all this uncertainty about how he was going to go. But he, 6 years later, on 75 milligrams of lorlatinib, is just getting on with life. And our biggest issue is trying to get him to come in for reviews because he's too busy doing things he'd rather do than come into hospital. And the people who can't see the picture, this is a photo he sent of us hiking in the mountains of Tasmania.
Wow.
Yeah, and for people who are in their car who couldn't see that CAT scan of the brain, I mean, can you imagine somebody alive on a mountain 6 years later after having that CAT scan for metastatic disease? All I can say is congratulations. You all and everybody else has done an amazing job in bringing this form of therapy, not to mention immunotherapy. We've gone from the worst thing to talk about in CME 20 years ago to the most exciting thing to talk about. Great job, and great job today trying to educate us more about where things are heading. Thank you so much to all of you. Really appreciate it. Audience, thank you for attending. Have a great day.